moving on to a slightly more controversial topic, Ipilimumab and Nivolumab are approved by the FDA in intermediate and poor risk, which is where the studies of Checkmate 214 showed where they showed a benefit over sunitinib therapy. But should this combination also be used in favorable risk patients?
Olga, I think it's a really important question and one that we face often in our clinical practice for patients with favorable risk disease. And there is really a spectrum of choices that we can present to our patients with favorable risk disease. They range from active surveillance alone with monitoring growth on repeated imaging. There's VEGF monotherapies that certainly these sector of patients seem to be more angiogenesis dependent, and so they tend to have, some of them have good responses to VEGF monotherapies. And then there's also the VEGF immunotherapy combinations that are currently approved as well. Ipilimumab-nivolumab combination is also a possibility, and I would argue that it has the highest rates of complete responses in this population at 13% based on the most recent 42-month data. And so when we're talking in clinic and discussing these options with our patients, I think it really depends on their own goals. And I can sit down with 4 different patients and talk through these options and have come out with 4 different outcomes. And so that depending on patient goals, what their hope and treatment goal are for the outcomes in terms of efficacy, as well as their tolerance for potential side effects. I think all of these options have to be presented, discussed, and then a choice made with the patient depending on what their goal for treatment would be.
Yeah, I do think it is somewhat counterintuitive that these favorable risk group patients did not have a clear benefit with immune-based regimens in the frontline setting. So I wonder if there are some biomarkers or serum, markers that we can use to try and guide us as to which way to go in terms of treatment. What do you think, Asen?
Ulka, I think this is very important question. I think this is a key area that we need something in our clinical practice. I think we have now all these wonderful agents that we can use in the clinic, but we really don't know how to select right patient for the right drug. We have IO, VEGF, or VEGF alone, and we really don't have any biomarkers. I think there is still a lot of effort going on. As we all know, there is some genomic markers like currently under like a development. One of them, I think, is PBRM1. Initially, looked in 2 different cohorts from Dana-Farber group, and then hopefully we can see the data for validation, and then after that we can apply to our clinical practice, but we are not yet. We have a tumor mutational burden, not so great in kidney cancer, but is very effective for other tumor type. We have microbiome markers, I think, currently tested in different cohort, including kidney cancer. But I think readily available is PD-L1, especially for favorable risk population. I think those patient population, if they have a high PD-L1 expression, personally, I'm comfortable to give them Nivo-Ipi because those patients tend to have more CRs and PRs if they are PD-L1 high, versus if they are PD-L1 low, we can do IO-VEGF or VEGF alone. Because of this reason, I think there is an area that we can use in our clinical practice. I think the key question is still we don't know those patients are mainly angiogenic or immunogenic. And there is some gene signatures presented from like Atezo-Bev trial, and then after that the Javelin trial. And those are also looking very promising, but still need to be further validated before we can apply to our clinical practice. I think Dr. Voss presented very nice discussion at GU-ASCO from Memorial Sloan Kettering, and he pointed out inflammatory markers such as NLR, neutrophil lymphocyte ratio. I think this is a very powerful marker for prognostic per se, and especially for favorable risk patient. When we discuss in the clinic, should we surveil them or should we start systemic therapy? I think if they have a very low NLR, I'm very comfortable to follow up without any systemic therapy. And I think we can also start using those markers by itself or as a combination. I think this is a growing area. We still need to figure out, but I think the movement is on the right direction.
Mhm. Yeah, I agree with you, Asim. I think PDL1 is a really good marker to use in this setting, maybe, to try and see, because PDL1 positive patients clearly did much worse with the anti-VEGF TKI therapy. So that may be a way to separate out the patients within the favorable risk group who are likely to have a similar benefit as the intermediate and poor risk group with immune checkpoint-based therapy. Any other comments?
Yeah, the only thing that I would chime in with PDL1 is it's so dynamic, and we've seen that there is significant heterogeneity between different sites of metastasis. So I think if you have a fresh biopsy that's PDL positive, I think that is helpful. I don't want to suggest that I think doing a PDL stain on an old nephrectomy specimen would help guide therapy. I think it really needs to be a fresh specimen if you're going to use that as a judgment call.
Yeah, no, Matt, you bring up an excellent point with the heterogeneity within kidney cancer, as well as, having old tissue that is not quite representative of the recent biomarkers and what's going on with the tumor. Those are critical things to be considering, especially when we're making therapeutic decisions.